Okay, thank you so much for joining us today. I want to welcome everyone to the STS 2024 webinar series. Today's webinar is titled The Future of SAVR. Please note that this webinar is being recorded and will be available next week on the STS website and YouTube channels. At this time, I am pleased to introduce our STS moderators for this evening, Dr. Arnaoutakis and Dr. Kachroo. Welcome, and let me turn it over to you.
Thank you, Karen. Good evening, everyone, and thank you for joining us for this exciting webinar series titled The Future of SAVR. I'm joined by Dr. Puja Kachroo as my co-moderator this evening, as well as three other experienced and expert speakers who will be sharing their insights regarding the future of SAVR. Our first speaker this evening is Dr. Tsuyoshi Kaneko, the Schoenberg Professor and Chair of Surgery and Chief of Cardiac Surgery at Wash University in St. Louis. He will be speaking to us about the newest Notion 2 trial results, which really informs a lot of future implications regarding the role of SAVR in patients with aortic stenosis. Yoshi, thank you again.
Thank you, George, and I would like to start my talk. So I really want to focus on the Notion 2 trial, which is something that was presented at the cardiology meeting. So not all of the cardiac surgeons are aware about these findings, but will have significant implications in our future. So I thought this will be a great opportunity to share. So these are my disclosures. Everybody has probably seen the slide. The number of TAVRs has surpassed isolated SAVRs in 2015 and surpassed entire AVRs in 2018. And this was presented at the STS this year, but age under 60 in California and New Jersey, there was 46% of patients who received TAVR in that group. And to the right, this is from the Vizient data, patient under age 65, 47.5% of patients are receiving TAVR. So TAVR usage in younger patients are increasing. And these are some of the low-risk trials that have been presented. The Notion trial, the original Notion trial, had a 10-year outcome that was presented, which showed no difference between TAVR and SAVR. Partners 3 at 5 years showed no difference between the two. And Evolute Low Risk at 4 years showed no difference. However, the p-value was 0.05, so it was extremely close to having a difference. And there will be a 5-year outcome that will be presented at this year's TCT. So this Notion 2 trial was presented at EuroPCR. Again, none of the cardiac surgeons really go to EuroPCR, so we really don't hear about this. But this was a TAVI versus SAVR randomized trial. And this was in a younger patient population, aged under 75, and randomized to TAVI and SAVR 1-to-1. And it included bicuspid valves as well. This was the unique part of this study. A lot of these other trials that I've introduced really did not have bicuspid valve included. So their results out of 370 patients, these were randomized to 1-to-1. Intention to treat was about 1-to-1, about 187 in TAVI and 183 in SAVR. So these were the baseline characteristics. Again, very young patients, 71 years old, with STS of 1.1. And as I mentioned, both TAVI and surgery group had bicuspid aortic valves that was included. And you can see sort of the distribution of ages. On the tricuspid aortic stenosis, they were slightly older compared to bicuspid aortic valves, as you can see. So this was the essential results. So their primary outcome was death, stroke, and rehospitalization. When they compared the TAVI and surgery in the entire group, there was no difference. And there was also no difference when death and disabling stroke was compared. Some of the key endpoints that they saw, again, blue was favoring TAVI. So major life-threatening bleeding, new onset of AFib, long length of stay, and severe PPM was higher with surgery. And the red is the one that surgery had better outcomes. There was less permanent pacemaker implantation and less perivalvular regurgitation, which we all know. The key finding was this subgroup analysis that they did. So they compared the tricuspid, the trileaflet valve versus the bicuspid valve population. To the left is tricuspid, trileaflet, and there was no difference between the two groups. And when you compare the bicuspid cohort, the p-value was 0.07. So there was a trend towards better outcome in surgery. Again, this was not heavily advertised despite the striking outcomes that was seen. When they broke it down, the death, stroke, and rehospitalization, which was a primary outcome, was favoring surgery, although the confidence interval did cross 1. And this was mainly driven by the stroke and death, as you can see. It was not really driven by the rehospitalization. It was more driven by stroke and death. And the paravalvular regurgitation was better in surgery. So this was their conclusion slide. What they said was that TAVI outcomes in young bicuspid aortic patients were less favorable. So again, this was stated in the conclusion, and this really did not make the highlight of some of the interviews. So there's a website called TCTMD where they take out some of these high-end presentations, and there was an interview done to the principal investigator, Ordan Becker, and what he mentioned in the interview was that he said all patients had CT beforehand for screening, so we could disqualify them from enrollment, but we were pretty liberal, meaning that they really aggressively enrolled these patients to the trials. So there has been really heated up discussion about recreating the bicuspid TAVR versus SAVR trial. But if they excluded some of these borderline anatomies, you would not see this result. So in my mind, I don't think this trial is going to be replicated in the future. And henceforth, I think we have to really, really put emphasis on the results of this trial. There was another sub-study that was presented at New York Valves subsequently. And what they did was they looked at patients who were age under 70. Again, the original study was age under 75, and they took the patients under 70 years old. The numbers are very small, 81 patients versus 77. So again, the power is weak. However, it did show even further interesting results. Again, the baseline characteristics, the age was 68, STS was 1. So clearly younger and less sicker than the original Notion 2 trial. And the bicuspid valve was seen over 30% in this group. You can see that 36% in the TAVR group had bicuspid and 34% in the surgery group had bicuspid. Going directly to the sub-analysis, because the main results were the same, when they compared the tricuspid valve, there was no difference between the two. However, when you looked at the bicuspid, looking at the primary outcome, death, stroke, and rehospitalization, there was p-value of 0.05, meaning that surgery had better outcomes than the TAVR group. This was the subgroup analysis that looked at death and disabling stroke without the rehospitalization. Again, the p-value was not 0.05, but very close. So you can see that these were really driven by death and disabling stroke. Very similar slide to the ones that was in the Notion 2 original trial. But you can see that this time the confidence interval does not cross 1, meaning that it is statistically significant on the bicuspid aortic stenosis with lower death, stroke, and rehospitalization for SAVR. So again, I think it's time to discuss SAVR and bicuspids. I think this result is quite significant. Those who are not really involved in the cardiology meetings are not really aware about it, but I think there needs to be more discussion about SAVR and bicuspid. Thank you so much.
Thank you, Dr. Kaneko. I think this segues right into our next discussion of management of bicuspid aortic valve disease, and this will be presented by Professor and Chief of Cardiac Surgery, Dr. Sultan at UPMC. Dr. Sultan.
Thank you so much for the kind invitation. Go ahead and share my slides. Okay. Excellent. Okay. Here are my disclosures. Really, the major disclosure I'd say I have is that I perform both SAVR and TAVR, and that I'm very fortunate to have a highly functional heart team. This is a slide that Tsuyoshi showed as to how TAVI continues to increase over time, and bicuspid valves continue to be affected with it.
Dr. Sultan, it looks
yeah,
like you're
I don't
not
think we're
sharing
seeing
your
the slides.
presentation.
We're not seeing a slide.
Oh, excuse me. Thank you. Let me see. All right, let me try that again. All right, how about now?
Looks good.
Great, thank you. Okay, here are my disclosures, and as I said, my major disclosure is that I performed both SAVR and TAVR, and I'm really fortunate to be with a functional heart team. This is the slide that Tsuyoshi showed again, the rate of TAVI increasing over time, and bicuspids have really been a part of this increase as we move towards a younger and younger population. What's important to recognize again is as bicuspid or BAV is really a syndrome, highly common, about 1 to 2% of the population. And while valvular dysfunction is really the most common complication, it can be associated with ascending aortopathy, coarctation, endocarditis, and while there's some data that there's association with acute aortic dissection, this has really been dismissed. So if you look at the key lessons we've learned in the past decade for aortic stenosis, majority of them have to do with TAVI. We know that it's been a revolutionary technology to treat patients with aortic stenosis. We know that it'll likely continue to be the dominant mode of treatment for trileaflet AS, and that a multidisciplinary eval in clinic is likely to provide the most thoughtful and comprehensive treatment plan for patients with heart valve disease. Now, if you look at what does the patient want in this situation, right? The patient wants the least invasive option. They want zero risk of mortality and stroke, no pacemakers. They want to go back to work right away, a very short length of stay, and they want some sort of a durability or plan if their prostheses were to fail. They also don't want to be on blood thinners. So what the young patient continues to hear is that the newer bioprostheses may last up to 20 years or so, and then you can get it valve in valve and you're good. What that patient should really know is that these bioprosthetic valves are going to fail much earlier in life and not last as long as they were thought to last. And so what happens when you need to get your second or third valve intervention when you're in your 70s? Or worse, if you listen to a lot of the literature that comes out talking about TAVR first, and then what direction do you continue to go down? TAV and TAV, TAV and TAV and TAV. And again, by the time you're in your 70s, this can be extremely challenging. We also know that the early TAVR explant data was very, very humbling. And while this may get better with time, it's important for patients to recognize that these are what the data demonstrate now. Now, why is this all important? It's extremely important because most young patients with aortic stenosis have a bicuspid aortic valve. And if you look at the last 20 years of TAVI, they have been incredible with multiple pivotal trials and outstanding outcomes and really technology that has helped change the field. But really, none of these have focused on bicuspid aortic valve while we continue to treat patients with bicuspid aortic valve. And so what we've come to is essentially, you have an aortic valve, you've got AS and now potentially even AI, we try to treat them with TAVR. So even though TAVR has become the preferred strategy for high-risk patients and intermediate patients, and potentially with low-risk patients, when it comes to low-risk patients, whether or not TAVI is a preferred strategy depends on a multitude of factors. And those factors include age, annular anatomy, coronary height anomalies, aortic angulation. And if you look at it corresponding, BAV patients happen to be younger in age. BAV patients have more calcium, both cusp and annular calcium. Coronary height anomalies are much more common in patients with bicuspid aortic valve, and so is aortopathy. And the aortopathy is real and important because the risk of aneurysmal growth over time is not trivial. Now, since there's no dedicated RCT data, what does the real world data look like? It is rather humbling. So these are data that were presented several years ago, which showed really no major difference in mortality at 30-day or 1 year, but the stroke risk was nearly twice. If you look at more data coming out of Korea, that was actually carefully analyzed by the core lab. 10% of patients with bicuspid aortic valve, as expected, were type 0 or without RAF-A, and about 90% with RAF-A. And if you look at them, nearly 50% of those patients had excess or heavy cusp calcium. And as you look at these patients, the risk of morbidity and mortality with time, when you have a calcified RAF-A and excess cusp calcium, increases significantly. Not only that, the risk of PVL and likely the risk of stroke follows. And so when you look at it anatomically, the prevalence of calcified raphe is not small in patients with type 1. And then you have to think about commissural orientation. You have to think about coronary height. And the reality is that bicuspid aortic valve is not a bicuspid aortic valve, is not a bicuspid aortic valve. There's significant differences in how these show up in patients and how we treat these patients and how we size these patients, whether these patients are sized and treated at the level of the annulus, whether they're sized and treated at the level of the cusp, keeping in mind coronary heights, keeping in mind specifically lifetime management and valve strategy. So what does this all mean? So patients with bicuspid aortic valve with TAVI potentially have a higher risk of stroke, a higher risk of annular rupture, and a higher risk of PVL. And you're more or less guaranteed to have some degree of asymmetric expansion and higher degree of structural valve degeneration with HALT and HAM. These are data that have been shown in trileaflet aortic valves, which are likely to be seen in bicuspid aortic valves too. And so we think about, what can you as a surgeon do, right? So as a surgeon, we would recommend, and most of you likely already do this, get an EKG-gated CTA before you decide on it, before you're doing a SAVR. If a patient's getting a TAVI, obviously they've already gotten the CTA, but again, it would allow you to plan. It would allow you to understand if you are going to need an annular enlargement or a root enlargement, if the patient may benefit from a mechanical valve, which again in young patients has significant survival benefit and eliminates patient prosthesis mismatch, such as doing a Ross procedure. But if you are going to use a bioprosthetic valve, which again, majority of the patients are going to get, I would consider using something that has long-term data and the ability to put in large valves that will allow for valve-in-valve strategy down the line. So what does this all mean if we were to sum it together? Patients with bicuspid aortic valve can have a surgery or selectively a TAVR with relatively safe results. But age, life expectancy, anatomic considerations such as cusp calcium, annular calcium, aortopathy, coronary anomalies, and ability to do a TAV and TAP should all be considered while counseling patient. And truly having an actual multidisciplinary conversation in patients is absolutely critical for patients to make an informed decision. Thank you so much, and I'll stop there. Look forward to the discussion.
Thank you, Dr. Sultan. I think that's a really important point that anatomy is going to be driving who is going to get what therapy, and I think also patient comorbidities, and I think this will be better addressed in our next talk of atrial fibrillation in the setting of aortic stenosis as Associate Professor from Cedars-Sinai, Dr. Kiankhooy. Welcome.
Great, thank you so much. I will, let me share my slides. Okay, here we go. Well, thank you so much for the opportunity to speak about aortic valve disease and atrial fibrillation. So I have no disclosures. So atrial fibrillation is awful. As many of you know, there's a 5-time increased risk of stroke. Some of you may not know it's also associated with the 3 times risk of dementia. 1/3 of all AFib deaths are actually due to heart failure. And there's a 50% death rate at 5 years in patients who have an incident hospitalization with atrial fibrillation. It's been really interesting to hear the talks so far mentioning young age, patients less than 70 or 65 or even 60. What's probably not known is patients with atrial fibrillation, like I said, are at increased risk for dementia, especially those patients who are young, under the age of 70. And this takes into account all types of dementia, vascular dementia, senile dementias, Alzheimer's, and non-specific. And look at those hazards or odds ratios, I should say, 2 or 3 times greater risk. So this is a real problem, and it leads to an increased total mortality risk within patients who have AFib and dementia. So what do we know about AFib and aortic stenosis? Well, we know as the amount of LVH increases. So in patients who have severe LVH, there is an association of a concomitant AF diagnosis in nearly 50% of these patients. So half our patients who have severe LVH have a concomitant diagnosis of AFib. So what does the current landscape look like in cardiac surgery? If you just look at this kind of broad strokes, well, there was a recent analysis by Dr. Hunter out of WVU, where he looked at 100,000 patients, 100,000 Medicare beneficiaries. And this was recent. This was just the past 3 years after the 2017 guidelines. And what he taught us is that actually 80% of patients who have a concomitant diagnosis of AFib, who are undergoing cardiac surgery, actually have paroxysmal AFib. And this is different than what we used to think. And so by definition, if you have a patient who you're taking to cardiac surgery who has a preoperative diagnosis of AFib, it's unlikely that that patient will present to your clinic in AFib, and it's unlikely that that patient will be in AFib when you take them to the operating room. Because remember, paroxysmal AFib is just intermittent episodes of AFib that last less than 7 days. So it's very unlikely that your patients who actually have atrial fibrillation will present with atrial fibrillation when you take them to the operating room. And what's alarming is if you are to diagnose these patients, so if you do identify them as having paroxysmal AFib, it's so easy to treat. We've learned from Dr. Cox over the years that paroxysmal AFib is a trigger-based AFib, and these triggers primarily rest in the pulmonary veins or the posterior left atrial wall. And simply isolating these triggers is a highly successful way to treat paroxysmal AFib. And obviously, we all know now from the LAOS 3 trial that managing the left atrial appendage in these patients reduces stroke as well. So what do we know specifically about the aortic valve patients and atrial fibrillation? Dr. Hunter presented another great paper recently. He looked at 24,000 Medicare beneficiaries, again, post the 2017 guidelines. And what he showed us is not surprising. 30% of those patients who had aortic valve disease had SAVR, 70% had TAVR. What's a little bit humbling is that unfortunately, only 43% of those patients who were undergoing a surgical aortic valve had their atrial fibrillation managed. And most of the time, that was just by managing the left atrial appendage. Very few patients actually got surgical ablation. But the notion that your electrophysiologist is going to treat the atrial fibrillation, or your interventional cardiologist is going to treat the atrial fibrillation after the patient's had a TAVR, is debunked. If you look at this analysis, what Dr. Hunter showed us is that only 5% of patients who underwent a TAVR had either an interventional, an IC intervention or an EP intervention that treated the atrial fibrillation. So surgeons need to know that if we're not addressing the AFib, it's very unlikely that the EP or the IC will be addressing the AFib after that patient's had a TAVR. And ultimately, we have learned that managing the atrial fibrillation in the setting of a surgical aortic valve replacement has significant advantage when you compare that to patients who are undergoing TAVR, even in the short term. So we're talking 3-year stroke advantage of 30% and 3-year survival advantage of 20%. So I know often the conversation comes down to durability, TAVR, SAVR, new valves, old valves. But in the setting of atrial fibrillation, you are realizing these differences in patient outcomes way sooner than we get into with respect to valves. So you're talking about a crossover point at about a year and an absolute difference at these 3-year marks. So big differences early on in patients who have their AFib treated. So what do the new guidelines show? So I mentioned the 2017 guidelines. What do we know about the 2023 guidelines? So we all know that managing the left atrial appendage in patients who have a pre-existing diagnosis of AFib is now a class 1 recommendation. This is level A evidence, mainly based on the LAUS 3 trial, which many of you, I'm sure, are aware of. And then the 2023 guidelines are different than the 2017 guidelines with respect to the way they categorize surgery. So the patient who's undergoing a CABG or aortic valve is now thought of as a closed atrial cardiac surgery. And again, this now comes with a class 1 recommendation, level B evidence. Obviously, we don't have any randomized control studies in this space, but we have lots of data. And just to kind of put this in perspective, when you talk about class 1 recommendations to treat atrial fibrillation in the setting of a closed atrial cardiac surgery, this is on par with Lima to LAD, and this is on par with what we're talking about today, which is treating the aortic valve in the severe symptomatic setting. So we are as well supported in the guidelines for the treatment of atrial fibrillation in this clinical setting. So let's kind of just finish here. We're talking about a real world example. So I had a 65-year-old male, EF was 50%, severe LVH, severe AS. He had paroxysmal atrial fibrillation. So what did I do for this patient? Well, again, based on our LAUS 3 data, which showed a substantial decrease in the amount of stroke in patients who had pre-existing AFib, who had their left atrial appendage managed, I indeed managed the left atrial appendage. And based on the mechanism of AFib of paroxysmal being trigger-based, my plan was to isolate the pulmonary veins and the left atrial posterior wall in one lesion set. So what I did was, I call it a non-atriotomy surgical ablation using the Encompass clamp. What's really great about this maneuver, when you're treating these patients, often they will convert to normal sinus rhythm in the operating room, which is great for surgeons to see. I AtriClipped the left atrial appendage and I put in a 25mm bioprosthetic valve. So a couple last points. When you are treating patients with atrial fibrillation, please consider continuing amiodarone post-operatively. Dr. Odd showed us in a randomized controlled fashion that patients who have any sort of treatment for their AFib, they respond better in the perioperative period with amiodarone with respect to freedom from atrial fibrillation. So please consider that. It is has been shown in randomized data. And finally, you know, this issue of pacemakers always comes up with AFib and AS. There's some really nice data out of Northwestern looking at valve surgery and permanent pacemaker data. This just came out. And what we learned from this study is that if you look at patients who were treated for their AFib and had valve surgery, if you waited about 6 days to treat these patients, you could not only decrease the amount of pacemakers that were implanted, but what's really interesting, if you follow these patients long-term, at 3 months, only about half of them actually needed permanent pacing. So many of these patients will ultimately have their SA node, have their AV node, and these patients will not require pacemaking. So thank you very much for that. You know, it's always great to talk about AFib in any setting, but this was fantastic with the opportunity to speak about atrial fibrillation and aortic stenosis. Thank you so much.
Thank you, Dr. Kiankhooy. That was a great overview on a very important topic. Our final speaker for this evening's webinar is my co-moderator, Dr. Puja Kachroo, who is Associate Professor and Director of the Aortic Center at Washington University in St. Louis. She'll be talking to us about managing the small aortic root, which there's obviously been lots of discussion around in the last several years, and particularly in light of some of the newly released data regarding the SMART trial. And so with that being said, Puja, please, we welcome you this evening and talking about the small aortic root.
Thank you so much, George. So I was tasked to talk about how to handle the small aortic root. I don't have any disclosures except that I do all sorts of surgeries, AFib surgery, TAVR surgery, and all of these surgical options. So the background is patients, we know that patients with a small aortic annulus actually have increased mortality, have increased cardiovascular ischemic events, as well as an increased risk of stroke. And it's really from the presence of this prosthesis patient mismatch that we have this increased mortality, because generally you have worse valve hemodynamics, and that leads to increased structural valve degeneration, and also later on will lead to less LV mass regression after the valve replacement. And so PPM is defined when this effective orifice area is too small in relation to someone's body size, and it's graded on mild to severe, and when obese patients has some lower cutoffs. This was a study actually by the World Alliance of Societies of Echocardiographers, and it looked at 15 countries from 2016 to 2019, about 1,500 patients, and really looked at what are the actual annular sizes. Now, in this study, about 40% of the patients were Caucasian and 40% were Asian. So just to keep that in mind, but the aortic diameter, as you can note, in men between 18 to over 65 really runs in that low 20s range, and in women about the 19 range, so a bit smaller. And according to race, in Asians actually was not very different in men than Caucasians, but was slightly different in women. But how do these studies define a small annulus? So it's important to note that we can all assess annular size before we get to the operating room, either with 2D, TTE, or TEE, but that generally underestimates the size. And so the best methods available are 3D TEE, as well as CT and MRI, and we usually use this in the TAVR world. But a lot of these studies actually used either HEGAR dilators or the valve sizers that we get within our valve kit. But so there's four options, really. How do we address this? We can either replace the valve with different types, either stentless, stented, or sutureless, and I'm going to go through all of these. We can do an aortic root enlargement. We can also do an aortic root replacement or a Ross procedure. So these are some of the valves that are stented valves. Now the trifecta valve was taken off the market last year, but they all come up with an inner diameter, an outer diameter. All these sizes are different and can be placed either supraannular or interannular. This was actually an interesting study that tested from 4 different laboratories from Abbott, Corkum, Edwards, and Medtronic of different valves. And this is a steady forward flow tester. So essentially they placed this valve within a tube and ran a medium of a fluid through it and checked the flow rate and the pressure differential across it, and ended up getting an effective orifice area, and then calculated based on that the effective orifice diameter. And it's interesting to know, and I just picked this, and no knock against these 2 valves, all sorts of valves had similar data, but the Magna Ease valve, you can see a 19 sizer for Magna Ease, the effective orifice diameter was actually closer to 15. In the 31 valve, it was about 24. So they're considerably different. Even for the Avalis valve, it was 21 to 15, or 27 valve was about a 20. So pretty significant size differences of what we're looking at. These are a number of studies looking at stented valves and the different rates of prosthesis patient mismatch. And they all looked at valves sizes below 23 millimeter. And again, varying different types of valve. The postoperative mortality was not low, anywhere from 1 to 7%. Initially, some of the valves already had about a 50% moderate to severe PPM rate. And as you can see, some of these valve studies that showed on their follow-up, the 5-year data, there was about 30% mortality, but more significantly, look at the moderate and severe pacemaker rate, as well as, patient prosthesis mismatch rate, as well as the severe rate. Now they're all up in the 20s to even up to 70% with some of these stented valves. The other option for valves is a stentless valve. One of the ones that commonly can be used is this freestyle valve that involves actually potentially having to do a root procedure. So these are a couple of studies. The top 2 are retrospective studies. The bottom 2 are randomized control trials. Again, comparing a stentless valve versus a stented valve. Both sizes about 21. The operative mortality is about 3% for this. And they followed these patients up but really didn't present any of their data for having PPM rates. But looking at the freestyle versus the trifecta, which is no longer on the market, under 23 size, this was a randomized trial. They did great. Postoperative mortality was 0. But again, even at the initial operation, they had about a 10% moderate to severe PPM, even with a freestyle valve. And at their 1-year data, it was about 16%. Nonetheless, they said stentless valves were better and led to increased LV mass regression. So they do have slightly better hemodynamic performance. So those are some of the advantages with the stented valves, but there are significant disadvantages to some of these valves. Pseudoaneurysms are more common. The reoperation will become more difficult because of the fibrosis and the calcifications in some of these valves. There's a failure rate in these leaflets with the prolapse that leads to severe AI. And a study showed that there was increased structural valve degeneration rates in patients who were under 60 years. And if we're really planning for the future, the valve-in-valve is TAVR is actually is a challenge with these procedures. In these stentless sort of valves, there's no markers. And so when aligning the TAVR, it makes it very difficult. And especially if a patient has AI, the route of opacification actually becomes difficult. And if you don't align the TAVR valve within that ring of Dacron, it can actually embolize. And it's more common to have coronary obstruction in these stentless valve replacements versus a full root replacement. So the other option, a sutureless valve, either the Intuity or the Percival valve. A couple of these studies now look at the Percival valve, but you can see that while their postoperative mortality was not that significant with this, you can see already the moderate to severe PPM rate, even with a large size Percival valve, was up about 60%, and even in smaller ones compared to stented was no real different than the stented valves. And on their 1-year follow-up, they presented their mean gradients only and not the PPM rates. But again, the gradients in all of these valves were already in the mid-teens. So unlikely that a lot of these valves are going to last more than 5 years. Some of the surgical options for annular enlargements, I just went over just a couple posterior enlargements and not the Roscono for an anterior, but you have the Nix enlargement that incises the non-coronary sinus and goes through the LVOT. The Manoogian incises the non-left commissure onto the anterior mitral leaflet, and again, enlarges the LVOT. You can sew a patch on and size your valve that way. With the Nix, maybe one size up, Manoogian potentially a bit more. You can do any variation of extended type of annular enlargements. There is the Y incision annular enlargement that really enlarges just the functional annulus and not the LVOT because it doesn't go through the virtual basal ring, but incises the non-left commissure and extends laterally to both trigones, and you sew on a rectangular patch, and then again can enlarge these for several sizes upward. Some of these studies looking at aortic root enlargements, and now this doesn't include the Y annular enlargement, but are looking at studies with annular enlargements as compared to the stented valves. And most of them are all posterior enlargements. This mortality actually kind of varied anywhere from 1% to up to over 7% with the addition of an annular enlargement. The PPM rate, even with an annular enlargement in several studies, was anywhere from 25 to 42% on the initial operation, and then on follow-up at 5 years was already at 30%, and in some studies up to 75%. So potentially we may not be doing an extensive enough enlargement or utilizing the wrong type of valve, or a number of reasons could explain this. Some people propose doing a complete root replacement with this procedure. This was the original Bentel procedure in 1968. There have been many modifications of it. You can also, in a redo setting, could do Cabral. But this was a study from the STS. Now this is dated up to 2010, 2004 to 2010, looked at 13,000 patients who underwent aortic root replacements, and looked at about a third underwent a mechanical valve and about a third underwent a stentless valve replacement. But it's interesting to note that only 5% of centers perform more than 16 root surgeries annually. So that means the median number of root surgeries per center annually is actually 2. Which for most centers is actually not much of a experience with doing root replacements in general. Now, looking at the outcomes, you can see that the operative mortality just to do a root replacement on aortic stenosis is about 6%. So while it's in line with some of the posterior annular enlargements and things like that, it doesn't come without risk. Stroke risk is about 2% and the increased reoperation rate. Now, it's not very much different for AI cases. The bottom half includes it, except for maybe valve sparing, but that's not the point of this case. The Ross procedure was described in 1967. It's had a resurgence now, that data showing that there's a match to the general population in a certain group, but essentially replaces the aortic valve with a pulmonary autograft and replaces the pulmonary root with a homograft. And so some of the advantages, it most closely represents a normal pattern of blood flow around the aortic root. You avoid long-term anticoagulation, and you have decreased risk of this leaflet thrombosis, which can lead to structural valve degeneration. But some of the disadvantages could be the potential for autograft failure or homograft failures. And in these patients, they require lifelong follow-up and monitoring. Now, this was an amazing study, and it's very important to note that these are very expert surgeons, root surgeons, expert centers, and very limited surgeons who are doing this operation. And you can see the operative mortality is anywhere from 0.3% to 2%. And that's not the case for most. And I think that data is going to start coming out when we look at the STS review of the Ross operations. But again, this provides a really good follow-up in patients, even especially with aortic stenosis. But in conclusion, really, I think it's important to identify a patient who's going to have prosthesis mismatch preoperatively, again, not by using dilators or valve sizers within the operating room, but we're really using that 3D TE or CT scans that we get for every TAVR patient is the first step, and that avoids PPM in the operating room. I presented a number of techniques that you can use to address small aortic roots, and really we have to tailor the operation to the patient's pathology. Not every single operation is going to work for everyone. And it's really important to weigh the comorbidities if they have atrial fibrillation, adding that to a complex, root enlargement, that's going to be a very big operation. And you also have to identify your own surgical expertise, because really that's going to limit it. If you're not a great root surgeon, you shouldn't probably be doing a Ross operation or doing a root replacement and potentially doing something that's less risky, getting the patient alive, or referring to high volume set. Thank you so much for your time.
Thank you, Dr. Kachroo, and all of our other speakers for excellent talks this evening. That wraps up our scheduled talks. There is one question in the chat, which I think got moved over to the closed section, but I'll just read. One of the major problems with surgeries involving aortic prosthesis implant is a residual gradient. And this question obviously relates largely to what you just went over, Dr. Kachroo. And so unlike TAVI, where we've seen that gradients can be smaller, apart from the surgical techniques described, this question says, what about dilating the annulus with balloon catheters or other techniques during the surgeries to enlarge the annulus? And so I personally don't have experience, and I don't know if any of you, apart from the surgical techniques described, have ever utilized anything of that sort.
I think we all know in a calcified root, it's going to be very difficult to really achieve a good result with just balloon dilation. That also risks, use, especially in a bicuspid patient who's had that significant LVOT calcium that can cause a potential aortic root disruption. So I think that's probably not the technique that is going to be durable, and it's probably not going to help us implant a larger prosthesis for a lower hemodynamic sort of result.
Yeah, I would tend to agree. I have a question for Dr. Kiankhooy. This frequently comes up on the surgical setting. Yeah, and I was really glad that you mentioned what your protocol is for postoperative medical management. What about anticoagulation in these patients? How do you approach that? It's a question I feel as though I receive on a weekly basis. Share with us how you approach that.
Yeah, I mean, it's a complex issue, and unfortunately, we don't have randomized data that really speaks to what we should do post-operatively if we've surgically managed a left atrial appendage. But what we do have is we have really large STS Medicare retrospective analyses that basically tell us that, look, if you manage the left atrial appendage in someone who has AFib, and if you compare those to patients who did not have their appendage managed, obviously their stroke rate is lower. And if you look at patients who have postoperative AFib and they have their left atrial appendage managed, and you compare that to that same clinical scenario with blood thinners, patients who are on blood thinners bleed more, right? It totally makes sense. You're not off blood thinners, you bleed less. You're on blood thinners, you bleed more. So then what does that mean when you talk to the patient? So I think firstly, it's a shared decision-making, right? You have to talk to the patient. You say, look, here's the clinical scenario. I know you want to get off your blood thinner. We have really good surveys that say that one of the driving forces for patients to have their AFib treated is to get off blood thinners. You have to say, look, maybe this is not the question that you're asking because I'm talking more on the patient side, but I tell them, look, your risk of bleeding is higher on a blood thinner than your risk of stroke now with your appendage managed. So typically we decide together, we're going to keep them off blood thinners. If you're asking, what do I do immediately post-operatively? Again, it's that same thing. I tend to just keep patients on DVT prophylaxis sort of medications. I've managed their left atrial appendage. But again, it's within this context of telling them that I think your risk of bleeding immediately post-surgery is higher than your risk of stroke now that your LAA has been managed. And so I think it's a very transparent conversation, and I let them know their stroke risk isn't zero. It'll never be zero, but their risk of bleeding is probably higher.
I think I just want
Can I sort of ask a question in that realm? So, you see a patient in the heart team, right? Patient comes in, 71-year-old paroxysmal AFib. You get a CT scan. They're a good candidate for TAVRs, right? So what kind of conversation takes place at Cedars-Sinai? I mean, is that patient going to be shifted towards SAVR plus AFib? Number one, do we have enough evidence? And number two, most importantly, I don't think the patient's going to want it. I mean, patient will want TAVR and then, treat AFib later on, especially if it's paroxysmal AFib. How do you guys deal with that?
Yeah, so I think that's a great question. I think there's two components to it. Number one, somebody has to treat the AFib, right? So we know that the EP or the IC is probably not going to address it. So then you have to say, okay, given the circumstance that this patient is going down the non-open cardiac surgery route, right? They've committed, their cardiologist, their internist, everybody's telling this 71-year-old, you have to get a TAVR, you have to get a TAVR. Then I think you have to say, okay, what else do I have in my AFib skill set to treat the AFib? Well, just because they've had a TAVR doesn't mean that you can't do an epicardial closed chest surgical intervention, right? You can do a VATS left clip. You can do a convergent. You can do a VATS maze. There are other options for that patient where as surgeons, we can still treat their AFib after they have their TAVR. And personally, what I do is I keep a Excel sheet of everybody who's undergoing a TAVR who has AF. 3 months after their TAVR, they see me in clinic because I know their AFib is not going to be treated by their EP or their IC. And I have the skill set to offer those closed chest interventions.
Great. There's a question in the chat. What predicted risk of mortality? And I think that this is improving, we can all agree upon, but in general, should we quote patients who need to undergo SAVR for a failed TAVR, essentially a TAVR explant?
Well, I'll go first then. I think
go ahead.
First, there's STS risk calculator. Now they've incorporated the TAVR explants into the model. So you can actually go into the STS risk calculator and calculate. But I would say it's going to be somewhere between 10 to 20. I think the recent data has been around 10%. But I don't think it's unfair to quote anything lower.
Yeah, and just to highlight to all the attendees, a link to the STS risk calculator is in the chat, which probably most all are familiar with, but it is an extraordinarily valuable resource in counseling patients with aortic stenosis. Another question for Dr. Kiankhooy, what success rate do you generally quote patients when you use the Encompass clamp?
Yeah, that's a great question. And to be totally honest, we don't have that data out yet. We are actively getting that data together to actually put an abstract into the AATS. I can tell you that it's promising. Obviously, I don't want to speak to data that's not published, but mechanistically with the Encompass clamp, the idea of isolating the pulmonary veins and that left atrial posterior wall, it should treat about 80% of patients who have paroxysmal AFib effectively. But unfortunately, we don't have that data yet. We're all working really hard to get that out and get that in the public space.
Yeah, we'll all look forward to that. Regarding the bicuspid valve, Dr. Sultan, wanted to ask you, in your center, in light of the concomitant aortopathy that we so frequently see, and maybe, debunking some of the older notions about higher dissection risk in bicuspid valve patients, how do you all approach patients with bicuspid stenosis, aortic stenosis, and concomitant aortopathy?
Yeah, I think there's been a lot of expert, quote unquote, opinion articles that have been published as to when it's okay to do a TAVR in patients with the bicuspid aortic valve and how aortopathy may be relative. And just because there's a class 2A indication of treating the aorta when you're doing an AVR for any patient, bicuspid or trileaflet, that you don't necessarily need to do that if you're doing a TAVR. What's more concerning is the talk track and the narrative that once you fix the valve, that the aorta is not going to dilate. And I think this is highly prevalent specifically in the cardiology community and even in the surgical community. And we know that this is not true. These patients need lifelong surveillance if they have some degree of aortic dilatation. So what I would say is that if they are borderline, or certainly if they meet indication for treatment for their aortopathy, that unless they're higher prohibitive risk, we would recommend that they get concomitant surgery at the same time. I would argue that an 80-year-old who may have a 4.7 centimeter aorta and a bike probably is not going to have a survival benefit. But I think outside of that, as we talk about how the risk of TAVR explant is not high just because of the simple TAVR explant aspect, but because by the time you're treating these patients, there's 2-3 concomitant issues that are going on. Their AFib may be worse by now, they may have coronary disease, they may have mitral valve disease, and now they have an aortic aneurysm. So I think all those things are important to take into account as we talk to patients.
I think we have a question in the chat, and I think I'll ask the other panelists about the Ozaki procedure in your center. Have you used it? What's your experience with it? Have you noticed the improvement in gradient mortality at the end?
Dr. Kachroo, I'm so sorry. We're having a little hard time hearing you. Maybe just repeat that one more time. Thank you.
My question was to the panelists about their experience with the Ozaki procedure. Someone was asking about in the chat about having a lower mean gradient, and if any used it, really how long does it take? What is your experience with it? What's the long-term longevity procedure? If any of you have any experience with it?
One of my partners actually does a lot of them. I think Danny Chu has one of the largest experience for Ozaki. I mean, I personally am not a believer, but it does have low gradient. It eliminates patient prosthesis mismatch concept. The concern I have is that, a lot of these patients fail with AR, not with AS, or typically with mixed valve disease. And so even though the narrative is that you could treat them as a basic, just a native TAVR, that's not really true, because the cusp height that you design and sew in are much taller. And so the risk of coronary obstruction is not trivial. So you're essentially doing some sort of native leaflet modification and TAVR, assuming there's going to be development of cusp or annular calcium, which may not necessarily be the case. So again, from a lifetime management perspective, I don't think that jury's out there yet. I would much rather just put a stented valve in.
I guess I want to ask this question to panel, really about the small aortic groove in the annulus, and with the SMART trial coming out and the data to be better in self-expanding versus balloon expandable valves. But really, how did that sort of impact your practices? And does that push you more towards being TAVR first in these small annulus patients? Let's say intermediate ones.
Yeah, that's a great question. I mean, we have migrated in patients reasonable to surgery toward surgery up front, and that's one of the great uses of everyone's enhanced familiarity with these gated CT scans. Our preference has been in many of those patients who are best suited with TAVR to resort to a self-expanding platform first. The one caveat to that, and I was going to get into this in a question for Dr. Kaneko in the Notion 2 trial, is some of the concern, or maybe it'd be a theoretic concern, about difficulty with the next option with TAVR and TAVR, and some of the challenges based on the design features of the self-expanding valves. But all things being equal, and someone higher risk for surgery who really should get TAVR up front, we've migrated toward self-expanding in light of some of the hemodynamic results, at least, that have come out from the at least this earliest report from the SMART study.
Yeah, I agree. I mean, I think the SMART trial was an industry-sponsored trial. It was not an NIH-sponsored trial that compared the two devices, and one of them was the sponsor of the valve that showed superior outcome. So, although it was a randomized control study, I think we have to take it with some degree of grain of salt. And the overall results, at least what they reported, the primary outcomes did not show any difference. So there was no mortality benefit to one over the other. I mean, I think it will be super interesting to see the long-term outcomes of it. And we all know that the self-expanding valves has better hemodynamics. So I think it comes down to whether you believe that or not at the end of the day. And to Dr. Kachroo's point, I think if the patient is intermediate risk, low risk or intermediate risk, and if the patient is thought to have patient-prosthesis mismatch even with TAVR, I think those patients we should aggressively be treating with surgery using all the techniques that you've shown, in your presentation. So I think all of that is going to be super important.
I mean, I don't know, Yoshi. I don't agree with most of the things you just said. So, I mean, all these trials by definition are industry-sponsored trial. I mean, I'm just glad that there's a head-to-head comparison, because I mean, you're the chair for the research registry. I mean, we can't. I think it'd be great to have some sort of head-to-head comparison and some funding to do that. I mean, but quite frankly, I think it's challenging to do it. I mean, I agree with you. I think we should, if that's the case, then we should take all these trials, with a grain of salt, as we should, and have some sort of scientific mind. I also think, if you start with a lower gradient, that's a good thing. That's not a bad thing. I mean, I think if you're starting with a higher gradient, that's probably a bad thing. And I think all of a sudden we can't decide that for decades we've used echocardiogram to judge how valves act and how prostheses act, and all of a sudden, some valves are so special that they need invasive monitoring. I think that's just
okay. So all the trials that's been done, right? All the trials, say for instance, Partners 3, they compared a Edwards valve to a surgical valve series, right? And then the Evolut trial, they compared the Medtronic's valve, TAVR valve, to all the surgical valves. This one in particular is comparing Medtronic TAVR valve to Edwards TAVR valve, and it was Medtronic sponsored. And that's all I'm saying.
Yeah, I'm with you, but I think right. I mean, there's a bias everywhere, right? I mean, there's all these trials went in with the hypothesis and the goal that with the point that TAVI is going to be superior. I mean, regardless of what manufacturers these were being pitted against, none of these trials going, oh, you know what, we're not going to see non-inferiority. I mean, there is an objective before you walk in, and spend
we just have to take that with
hundreds of millions of dollars over the past decade.
I think it's interesting to note that even with this randomized control trial, even industry sponsored, they still published that even in 1 year, they still had about an 11% moderate to severe PPM rate. And that's after knowing, all the data TAVR CTs, and they still couldn't predict in this 10% of their patients, they still have PPM. So I think that's important to note that even if you're going the TAVR route, that I think we still have to keep that in mind and really look at EOA and if it's good enough for the body size and for the patient.
And the questioner in the chat did mention an upcoming publication about their balloon technique with surgical experience. So I'll be excited to look for that coming out. Speaking of the small route in terms of patients going for surgery, I do think a freestyle is an excellent option. Admittedly, can be a challenge down the road, and so certainly many of these. In fact, I have a patient in the hospital who had a freestyle 20 years ago and now has AI and certainly doesn't have core knot in place. But just wanted to poll our other panelists as far as how many of you use core knots in root replacements as a radiographic marker, or any other tips or tricks that you use to set up down the road for radiographic guidance.
Well, I'll,
Valve TAVR, George? For TAVR.
For
TAVR.
when doing a freestyle and to set up for a TAVR and a freestyle down the road. Does anyone use core knots on their freestyles or even a composite?
I mean, I do, but I just assume that that's going to be a pretty, you know, I mean, I think we've all done of TAVRs and freestyles, but quite frankly, it's, you know, it's a lot of sphincter tightening and just you know, and hope for the best a lot of times. I think, you know, because again, it's like when we're talking about the Ozaki, the cusps don't calcify, the cusp tear. These patients present with severe AR. You know, you're fortunate. These are the times you kind of wish, you know, when you're reoperating on these, you hope that there's not that circumferential ring of calcium. But when you're doing a TAVI, you hope that there's some circumferential ring of calcium, you know, both at the annulus level and hopefully at the STJ level, and that'll hold your valve. So, you know, it's a little bit more secure than the core knots.
All right, one final question to post. Let's just poll all of the panelists. What the favored annular enlargement procedure used by you all, and of course, anatomy dictates, you know, many times which technique to be used. But what have you all migrated to in your practices?
Manugian. I still use the Manugian.
Me too, Manugian.
I think Manugian is a great option.
I use the Nix and extended. You can modified Nix, and then you can go down further on the mitral valve. And I've had no issues with upsizing by at least 2.
I use Y. I don't put 27s and 29s like Bo does, but you know, I think it's a simple replicated technique. So.
Yeah, well, great. Well, I think we're upon the conclusion here for our hour-long webinar. And on behalf of our other panelists and my co-moderator, Dr. Kachroo, I want to thank all of you for attending this evening and hope that this was valuable and educational.
Thank you so much.
Thank you.
so much.
Thank you so much to all our panelists today for your participation and insight. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts and benefits and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Plan to attend the STS Mastering Valve Surgery Workshop right here in Chicago, September 20th through the 21st. The program will feature both didactic lectures and hands-on simulation training in all aspects of valve surgery and atrial fibrillation. Learn more at sts.org. Thank you so much. Hope everybody has a great day. And don't forget to vote. Thank you.